Hello,
Okay.
Dr. Sumrall. Thank you for joining us on MD Newsline. You've been here before, but can you please introduce yourself to our audience?
Thank you, Esther. So I'm Ashley Sumrall. I am a neuro-oncologist, and I'm the section chief of neuro-oncology in Charlotte, North Carolina for Atrium Health Living Cancer.
And you did a great oral presentation today on some research that you've been conducting. I would love to hear about that.
Thank you. One of the areas of interest that I'm very passionate about is brain tumors that are especially difficult to treat. They're all difficult, but there is a small group of patients who have what we call diffuse midline gliomas, and they have a specific mutation affecting what we call H3K27, which is a mouthful. These tumors affect children and young adults, and also affect some adults up into their 40s. And what I presented was an updated analysis of data for a drug called Dordavaprone or ONC201 in the adult setting and the pediatric setting. And essentially, we demonstrated that there are response rates that we can see and also that the treatment is well tolerated. So, one of the things that we found is the overall response rate is about 20% when you look at both groups combined together. And that is just one goalpost. Something else to consider is that maintaining or improving quality of life is very important. And then hopefully we will see additional prolongation and survival for these patients.
We don't often hear about adult and pediatrics in the same clinical study, but with such a rare disease, it kind of makes sense. What were your thoughts around designing the study in that way?
So these were actually two studies, but we put the data together. And, something that's surprising to a lot of people, some of our pediatric studies go up to age 30 or into the mid 20s. So our definition of pediatrics is evolving. But in this data, we took our adult group and our pediatric group and presented them together, again, because this is such a rare disease. One of the things that we're working on right now is a study looking at the same type of tumor, but in the newly diagnosed setting. So I've been involved in that work as well. It's very rewarding because these patients have no systemic therapy options. The only treatments that we have to offer them have been surgery, which is very difficult in the deep part of the brain, and then radiation therapy.
How do you interpret the objective response rates and duration of response in the context of maybe like historical outcomes for the disease?
Is really challenging. This particular subtype of tumor was only defined in 2021 in the WHO classification. So the history of this illness is very messy. You have DIPG, which is one type of deep brain tumor, and then these tumors. And so in some of the studies, those were put together. In both of these settings, we excluded the DIPG tumor. So you really have to spend a lot of time analyzing the MRIs, and that includes both contrasted and non-contrasted images. And so I may spend an hour examining an MRI and pulling up multiple versions of it and carefully measuring because it can be really tricky.
I'm wondering, there's been news lately about artificial intelligence being used to analyze results of exams. Have you thought about integrating that into your work at all, or is it?
I will tell you, I can't wait.
Yeah.
So I saw a presentation this week about machine learning and how to train them to look at MRIs and to teach them. We do have data for pathology and then also some imaging studies like in mammogram where putting human intelligence and AI together improves outcomes and it allows you to get through that work more quickly. There's a presentation today at ASCO by one of my friends that I'm excited to see again, learning how to use this in our everyday life.
And I'm wondering, just, I've spoken to some researchers, and there seems to be a challenge of needing to understand how to use things like machine learning models, and that's a hurdle in and of itself, beyond and completely separate from actually doing the research. And I feel like with this evolving kind of landscape, it almost feels like new roles need to emerge.
I
What do you think about
I
that?
agree. I have several friends who've been interested in AI and bioinformatics. And so it's funny, I sat down with one of them and asked her questions yesterday. And there's just so much to learn. One of the speakers this week said, "You've just got to get out there. You have to put the puck on the ice," which I thought was a great analogy. So even if we don't feel confident in how we work with these models, I think we have to practice using them. They're the consumer-based ones, such as OpenAI, ChatGPT, Gemini. Open Evidence is another one that's become really popular in the clinic setting. And so I think as clinicians, we have to start using them and practicing with them. And that will help us because people are writing clinical trials right now using AI to help us find patients, analyze data. And ultimately, as a cancer doctor, if that can accelerate how we get treatments to people, we should all be really enthusiastic about that.
Hmm. Yeah, I was speaking to a researcher, actually, preclinical researcher. They're studying the movement of mice that had Alzheimer's gene
Hmm.
inserted, and she is basically a programmer. Like, I mean, she is. That's
Yeah.
her thing.
Yeah.
So she learned it, and she was talking about building models for other labs to use
Hmm.
because it's not realistic to say, okay, also learn how to train a machine learning model. So it's
Right.
interesting how that kind of subset or field of work is a hybrid that can build and maybe maintain models across
Yeah.
specialties. But back to, sorry, go ahead.
No, I was just going to say it's really interesting because I've heard presentations this week from Microsoft and Google, and these are companies that have not been in the healthcare space. And you can hear the enthusiasm when they talk about trying to use their background and the way that they problem solve in the healthcare setting. And honestly, we have a lot of places where we could use some help. So I think it's really fun to watch non clinical people become introduced into this space. And ultimately, what happens is you are helping other people, and that makes everyone feel good and invested, and
Yeah.
it helps.
Yeah, I'm super excited to see what happens, but your comment about looking at the images really brought that to mind again.
It's really neat. One of the models that I saw was how to incorporate different AI tools to do tumor boards. So our traditional tumor board, we sit around a table, we each bring our expertise. And so, what if you have these models that have learned and they can help you? I mean,
Yeah.
it's just really cool to think about.
So, back to your study and
Hmm.
Dordavaprone,
Hmm.
how do you communicate, or what was the conversation around maybe the potential benefits and limitations, maybe some
Hmm.
side effects for Dordavaprone,
Hmm.
especially considering the side effects, are they different among pediatric patients versus adult patients, and how do you handle that?
There's a little bit of a difference, but when you look at the data sets, they're small data sets, and the pediatric group is small as well. The first thing that I tell people, the way that we classify serious adverse events, or if we have grade 3 or greater events, there were zero serious adverse events. There were zero cases of death due to the drug. And as far as the events that were dose limiting, that was also pretty minimal. In all of our studies where we have patients with brain tumors, we have fatigue and we may have some nausea, but nothing really stood out. In the pediatric group, the blood lymphocyte count came down a little, but there's a striking difference between some of our studies where you have a laundry list of all of these problems that you create with your therapy, and so we're very fortunate that this therapy is well tolerated.
I'm wondering, just can you tell me a little bit about the current understanding of the biology of the H3K27M
Mhm.
mutant gliomas, and how does that inform drug development?
Mhm. It's interesting because when I first started working with this drug, we were not sure about the mechanism. So
Mm.
much has evolved. We know it's a ClpP agonist and it's a DRD2 antagonist. So essentially, it helps to adapt or modify the changes to H3K27, which is trimethylated. So the downstream effects are stopped. Um, and this also leads to a response rather quickly, that's evident in the patients.
Um, I would, I mean, just kind of off of that, are there biomarkers or other biomarkers or clinical features that might predict which patients will respond best to Dordavaprone?
That's an area where we're trying to learn more. So, one of the limitations that we have, these tumors are deep in the middle of the brain, and so the tissue samples are very small. In one of the studies that's ongoing right now in the pediatric population, they have the opportunity to look at more biomarkers. Something I'm excited about is we're now starting to use more CSF based biomarkers as well. And so, I'm hopeful in the future that we'll know more and we'll be able to predict who would be a better responder. um, Biomarkers have really revolutionized how we treat patients with brain tumors.
Yeah. What do you see as the next steps for Dordavaprone in clinical research? And are there plans for combination therapies or new trial designs?
I mean, it is really exciting right now. So the company has tried, the company that has fostered this drug through development, has tried to push it forward. And so currently, the FDA has an application for accelerated approval, and hopefully we'll know by the end of the summer about that. We've been participating in the ACTION study, and in that trial, you introduce Dordavaprone in the newly diagnosed setting. And then there's some other studies that are ongoing. The action study is still open outside of the US, but it's on pause right now while the FDA is considering the application.
Mm.
If we have a drug approval, then that really opens the door for additional studies and combination therapy. So it's a really exciting time to be involved with this area of research.
I'm so curious because, the H3K27M-Mutant diffuse midline gliomas are very specific.
They are.
They're very niche.
It
What
is.
drew you to that specific area?
I'll be honest. In 2021, the WHO classification for brain tumors changed. And so from that, multiple new tumor categories um, developed. And of course, this was during COVID. It took a while for all of that information to catch on. We were all so, inundated with everything. And I was taking care of a patient in the hospital, and the pathologist called me with his path report, and she had checked it and found one. And I said, "Well, I need to." I need to go read about that. So I started reading and talking to colleagues, and there was a presentation, either from ASCO or SNO, about this drug. And so my very first patient, we had permission, to use the drug off label. And the more I read, within 2 weeks, I had two more patients, which was very unusual. And I was actually able to open the clinical trial in 2 weeks, which has never been done at my facility. And so we dove right in taking care of these patients, and being able to offer them something, knowing that there were no other choices out there, was really thrilling. And so I've been working with these particular types of brain tumors now ever since.
Speaking of choices, the landscape of a lot has changed in our country, just as far as advocacy,
Hmm.
access. I'm
Hmm.
sure there are things going on with shortages, insurance coverage, and things like that. What's been going on in your slice of the world, and how are some of these changes impacting your work?
It's been very challenging. So much of what we do in the clinic, in the exam room with the patient, depends on what's happening out in the world. And what is happening in DC affects what we do quite a bit. Some of the areas where I've been personally invested have been with prior authorizations, also Medicare and Medicaid. And then, of course, this concern of decreased funding for NIH and NCI. And so, you know, I'm I maintain I maintain a positive attitude where I can, and I think it's important to be an advocate. I think it's important to do simple things such as writing your congressional leaders and writing policymakers. It's important to engage at the state level because more decisions are being made at the state level as well. So, state and federal involvement on the personal level, involvement with professional organizations such as ASCO, um, and then being willing to continue to give input and give advice. What I don't want to see is that we become disappointed or that we back away from that mission. Ultimately, so much of what we offer our patients comes from NCI funded research. And we have to stand up and demand that we continue to be a leader in that area.
Yeah, I'm hearing that conversation a lot, and I hope that we continue to be able to continue that work over time because these trials need to happen over years. Um, I want to ask you just some follow up questions just about classification. So, how do you foresee classification evolving as we gain more insights from molecular and immune profiling? Do you think that that's gonna be heavily impacted, or what gaps do you see maybe in current classifications, if any?
Mm-hmm. Well, I think it also ties into advocacy. So we are at a crossroads right now in oncology where we have to have the ability to test tumor tissue for biomarkers. And that tumor tissue, it costs money to do that. We also do liquid biopsies that may be blood or plasma based or CSF based. And quite a few insurance companies do not cover this. So, a big barrier to care right now is not everyone has equal access to have biomarker profiling. And if you don't have that biomarker profiling, then we don't truly know what your cancer is. And so every year we gain insight. And just like some of the presentations here, one of the plenary presentations with ESR1 breast cancer, for example, if your doctor hasn't been able to test your tumor for that biomarker, then you don't even know if you're eligible for some of these treatments. And so the testing can be thousands of dollars. So, one piece of advocacy is pushing to have biomarker coverage by major insurers. And as we do that, we're going to learn more and more. And then we will take that information and modify our clinical trials. There are some tumor types, biomarker subtypes that we may think are rare that may be common. I mean, we've learned quite a bit over the last few years. So I'm hopeful in that regard that tumor profiling will become mainstream and become standard of care. And I'll also add that it's not just looking at the initial diagnosis, but every time a patient has a recurrence or change in their disease, there's an opportunity to analyze again. And so ensuring that we have access to that and that we're not placing undue financial burdens on patients will be really helpful there.
And speaking of people just not having access to
Mm-hmm.
molecular testing, what
Mm-hmm.
advice would you give to community oncologists or general
Mm-hmm.
pathologists who may not have immediate access to advanced
Mm-hmm.
molecular testing?
I would say the field has really exploded over the years, and there are multiple companies. So you can connect with those companies. Many of them have really developed patient assistance programs. There are some clinical trials where you can use profiling as part of the clinical trial and have it covered. So there are different avenues. And I really think that it is our responsibility as physicians caring for these people to explore every avenue to ensure that everyone has access, under your domain, that they have every opportunity to have the best care possible.
One thing I did want to ask you, just now knowing that these are two separate studies, what are there any clinical implications of distinguishing between pediatric type and adult type diffuse gliomas,
Mm-hmm.
and did that impact your treatment plan at all?
It hasn't impacted treatment, but a lot of us in this field believe that there is a difference between them, and it may be based on location, it may be based on behavior of the tumor. One of the pieces missing in this puzzle is the ability to analyze other biomarkers. And so again, we need tissue, we need access to testing. And so some of the newer studies that have been designed that are open in the US do allow for more biomarker testing. So I think that in the next few years we'll see more
Mhm.
to guide us.
What were the most exciting takeaways for you in conducting this study that you hope to kind of work on in the future and
Hmm.
maybe ultimately see implemented?
It I've had several patients over the years who have been treated with this medicine, and it truly is the day-to-day interactions with those patients. One patient who was able to live several years, to to be at home with her kids and to enjoy that time. Um, and when people come in and they say that, when we talk in the beginning, we talk about how average survival for this illness is around 1 year. And so when we're able to expand that into several years, and when patients are so grateful for that time and the quality as well, the quality of time really matters. It it is it is really life-changing and career-changing, and it will make you want to jump through the hoops and do what you have to do, um, to make that available for them.
We have
Mhm.
these highly specialized things like your multi-letter
Yeah.
focus area, and we have conferences like ASCO. What
Uh-huh.
we're finding is a lot of diseases multifactorial.
Absolutely.
It's
Mhm.
personalized medicine is like you have this genetic
Mhm.
mutation or this
Mhm.
epigenetic marker, and that
Mhm.
impacts how
Mhm.
your cancer, although the same as this other person, is going to react.
Yeah.
I don't see a lot of conversations across specialties. And I feel like that's where a lot of the real insights kind of exist. And also, you're a doctor. So who even has time, right? Even reading through the abstracts here is like so much.
It
And
is.
this is one thing,
It
right? But
is.
there's
Yeah.
so much insight.
Yes. Medicine is very
How?
siloed, and it's a problem.
Mhm.
It's siloed from specialty to specialty, and also from academic physicians to community physicians. And so one of the things that some of the leaders in the fields in oncology, what we're trying to do, for example, is to break down some of those barriers, to bring in patient advocates, to bring in nurses, other, health professionals into these decision-making groups. Um, in the world of oncology, a multidisciplinary tumor board is it's the secret ingredient. It really is, because you sit around the table virtually or in person with multiple specialists,
Mhm.
and you're forced to talk about cases together. We also have nurse navigator model in oncology, and so your patient knows that they have someone. Their goal is to care for that patient and to cross disciplines through surgeons, through radiation, and so forth. And then lastly, one of my favorite things that I do is I work with two other physicians in a multidisciplinary clinic. It's a genetic predisposition clinic for patients who are at high risk of cancers. So as a medical oncologist and a neuro-oncologist, I serve that role. We have a geneticist and an endocrinologist. And so we'll see patients together. We'll look at their genomic markers. We'll look at their germline testing, and then we'll decide how can we proactively look for cancers, and then we reach out to all those subspecialists.
And do those case studies stay there?
um, it depends. So if they don't have active cancer, we'll keep them in that clinic, but if they have an active cancer, then they'll come out. I say that I'm bringing them home. So I'll bring them to my separate clinic or to another, if I have a colleague who's better equipped to deal with that. But we always maintain that annual follow up with our geneticist in case, and our genetic counselor in case there's any new information, that has come out, something that we can collaborate together and make sure that that patient and their family, that they have access to.
I'm thinking about, machine learning, like I said, being used to analyze past clinical trials. These case
Mm-hmm.
studies get so specific.
Mm-hmm.
And, like you get diagnosed with a rare autoimmune eye thing that only a
Yes.
few people have and randomly in Chicago. And it's like, it's usually does this, but it's doing that. And then you're like, okay, well, we've kind of figured it out, but
Mm.
what if someone else has the same thing?
Well, it's
How
true.
can we, Northwestern has like, I think
Yeah.
it's called the New Gen something,
Yeah.
but like, I'm wondering, like, how do other people outside of that hospital system have access
Mhm.
to those insights from those cases? It
I
feels like
mean,
they're reinventing the wheel every time.
one of the things you can do is get online and start searching. And if you see a doctor's name pop up over and over, reach out to that person. There's a steep learning curve into how to be an advocate for yourself, in the medical world. And there are organizations that can help you, but if you hop on PubMed or you hop on clinicaltrials.gov, or now with AI, you can go to AI and do it and say, who are the experts in this area? Who has published the most on this? Show me, this data. And it's pretty easy to get contact information for those people. And if you have a physician that's publishing on something and that's their passion, they will love to talk to you. I mean,
Mhm.
I have patients from all over the world who message me with H3K27 tumors. And every time I'm like,
Interesting.
yes, I mean, I hate it. I don't want anyone to have it.
Yeah.
But if I can help them,
Hmm.
it's just such a gift to
Yeah.
have that knowledge and be able to help.
If you could leave us with, you know, I know there have been so many sessions here, right? Either something that has stood out to you
Hmm.
that you've seen in your time here at ASCO,
Hmm.
or just one final statement for
Hmm.
your fellow physicians.
Well, I have two of them, I guess. One study that really stood out to me that wasn't highlighted that much was a study where exercise was used as an intervention for patients with colon cancer, and it improved survival. So, what I loved about this study is exercise is free and available, and it makes a difference. And it part of that takeaway is that doctors and patients can partner together and do simple modifications in lifestyle, and we show that it makes a difference. Um, the message that I always give my friends and colleagues, and even my patients and their families, is to be an advocate for yourself,
Mm.
be an advocate for your care. And part of that includes educating yourself about what's going on in our country, and reach out to your policymakers, reach out to your lawmakers, share your stories. They do make a difference. Um, we are incredibly blessed to live in this country, and we have the ability to impact policy. So, if you want to have federally funded clinical trials for cancer, tell someone.
Yeah, that's a great place to leave us. Thank you so much for joining us on MD Newsline. It's been a pleasure.